Hello everybody. Today we'll talk about a topic which is very much neglected in our day-to-day critical care practices, and we often tend to overlook this because we do not know the harmful effects or the consequences attached with it. So today we'll have a discussion on sedation and delirium in ICU. Although it appears to be a very simple and minor topic, but the impact it has on the recovery of your patient as well as its post-term mortality as well as morbidity is very huge. So what do you mean by sedation? It is suppression of the patient's awareness to the environment. That is, you are reducing patient's responsiveness to any sort of external stimuli which you give to the patient in ICU. It comprises of anxiolysis, that is reducing the anxiety of the patient, analgesia, amnesia, that is making patient forget of all the traumatic events which he has faced in retrospective or he is going to face prospectively, and to a small component it even giving anesthesia, which is a subcomponent of it because we do not usually do it in ICU, but sedation in ICU is usually providing anxiolysis, analgesia and amnesia to the patient. So let us know a little about history of sedation, which dates back to 1995, wherein first sedation guidelines were given, wherein it was advocated that midazolam and propofol can be used for short-term sedation and lorazepam can be used for long-term sedation. So here it was a very rough kind of guidelines, like you give for short-term sedation and this is for your long-term sedation. It was not a protocolized guideline. But again then in 2002 we had a SAC guidelines, that is sedation and analgesic guidelines, which highlighted the importance of your daily sedation goals and daily interruption of your sedation, because they clearly understood that heavy sedation is neither very useful, light sedation is also can be harmful, and so they thought like there has to be a daily interruption of some amount of sedation and you have to give your sedation as per to a certain goals. What was the problem with the sedation goals previously was we never had an advanced ventilator machines which could synchronize with patient's ventilation. Neither we had a good form of analgesia which we could use for all the traumatizing procedures in ICU. So the dictum that time was giving heavy sedation or keeping a very deep sedation. But later on we came to realize that this deep sedation was in a way harmful. So they wanted to have a daily sedation goal as well as interruption of this sedation. But the drawback of interruption of sedation was, again when you want to bring back the patient to that higher level of sedation, the amount of dosage which was required to bring back the patient to that higher level of sedation was high. So in the advent of giving less amount of sedation dosages, we finally ended up in giving higher amount of dosages, that is the cumulative dosages became higher. So what happened? Again then in 2013 there came a very landmark guidelines called PAD guidelines, that is Pain, Agitation and Delirium guidelines in 2013, which emphasized on lighter level of sedation, provided we have a sedation scale and you algorithmize that scale as per to the RAS scales or sedation algorithm scale. That is, you titrate the sedation, you give light sedation, but titrate it to that particular RAS scales of 0 to -1 or sedation algorithm scale of 3 to 4. We'll know about it later. Finally, in 2019, we had an ABCDEF bundles, which described about assessment of the pain of the patient, everyday spontaneous awakening and spontaneous breathing trials, the choice of analgesia to be given, then the assessment of delirium, the use everyday exercise and mobility of the patient, and family engagements. So, what is the etiology of pain in ICU? Why do you want to give sedation and analgesic in ICU? So a patient in ICU is exposed to lot of things. He is exposed to lot of plastics, catheters, injections, and as various interventions, lot of traumatizing procedures. All these things contribute to pain in ICU. For example, a simple Foley's catheterization maneuver can be painful as well as the persistence of Foley's catheterization can cause intolerance. Endotracheal tube itself is a cause for high intolerance in a patient. In a patient in ICU, immobilized for a longer duration of time, presence of pressure sores are also cause some amount of pain. Immobilization and physical therapies, limb physiotherapies, chest physiotherapies also cause pain in a patient for which he requires definitely analgesia. Various vascular catheters like central line catheters, HD catheters, arterial line catheters, all these persistence of all these catheters inside the body are also a source of pain, as well as small amount of traumatizing procedures or minimal surgical procedures like debridements and other things, or placement of an ICD are all causes of pain.